Very good. So welcome back, everyone. We had a little bit of a challenge there getting connected. I apologize for the delay. I want to welcome everybody back to our COVID-19 Innovations webinar. My name is Gary Thompson, Medical Director for Quality, so I'll be your host today. Just a couple I guess comments before we do get going with our webinar today. I think everybody can appreciate, listening to the news that there may be a little bit of optimism out there with respect to maybe a flattening of the curve, especially in some of the hot spots in the United States, like New York. Here in Riverside County, we are seeing continued escalation at this point in cases. Just to give you the numbers, per the public health website, there were 946 confirmed cases as of now. There were 799 yesterday, so you can see there is a significant uptick. We are up to 25 deaths to this point. I think over the next week or two, we'll have a clear idea as far as the curve that Riverside County is on. I again am cautiously optimistic that our mitigation strategies will work, and we'll be able to work on flattening that curve. But as we've mentioned in prior webinars, we are continuing to work very hard in preparation, sort of hoping for the best, but planning for the worst. And that has been our goal since the beginning. Today, we are venturing back into the ICU environment, looking at some innovations in that area. We have the privilege of having Dr. Nikki Mittal on with us today. She's our pulmonologist and critical care lead within the ICU environment. She's been working very hard with other disciplines, working on surge planning and also looking at innovations within that environment to improve safety for staff and, of course, providers. Today, she will be introducing the intubation box. So this is something that you may have seen in the news as well, but Dr. Mittal, working with other members of the team, actually have developed a prototype and actually implemented the box for you to view. So without further ado, I'm going to hand this over to Dr. Mittal, and again, really appreciate her participation in our webinar today. Thank you, and Dr. Mittal, the floor is yours.
Hi, my name is Nikki Mittal. I'm one of the pulmonary and critical care physicians here at Riverside University Health Systems. We have spent a lot of time planning for this pandemic, and some of the things we've seen from other countries we thought we would bring here. We want to show you the intubation box that we took the idea from a physician in Taiwan and how we modified it a little bit to meet our needs, or what we thought may be a little bit better functionality. So without further ado, why don't we get this video started? Hi, my name is Nikki Mittal. I'm one of the pulmonary critical care physicians here at Riverside University Health Systems. In going through our preparation for this pandemic, we have clearly been taking a lot of ideas from other countries and what they've done to adapt to this. One of the things I saw online that I thought was very unique and potentially very beneficial is this acrylic intubation box. So I brought a picture of it to our plan ops guy, and they were able to make a box relatively quickly overnight, and they had their first prototype for us. They brought it up the next day, and we had all the people that intubate, essentially from the different departments, come try it out. So anesthesia, ER, and pulmonary critical care. We are, as you would expect, varying sizes. So one of the people in my department is about 6'3". I'm 5'2", And I thought that that would make it difficult for us to have the holes for the intubator at the same place. But when we ended up trying it out, it ended up working well. Um, the initial box that we saw didn't have holes on the side for the respiratory therapist, but when we tried to dry run it, we thought it would be better to have a hole on one side and then to adapt to the bed, which is potentially either way, to give us better protection. We did get a 10-15 tape from the OR and put it across. And that way, the side that the respiratory therapist is going to be on is able to be pulled back, and the other one is still covered, maintaining containment of the aerosolization. We know that a lot of the data out there says we should be using video laryngoscope for intubations, and so this allows you to bring the video laryngoscope, the blade underneath the box, while still maintaining a screen outside, with the respiratory therapist on the opposite end, able to back while you do all your manipulation. Height of the box, while it seems very high, it is appropriate for the size of someone's head with a bag or room for manipulation of an endotracheal tube if needed.
Hi, I'm Marty Starnes. I work for Hospital Plan Operations. Dr. Nikki was approached me to ask me to build the box. I was the one that came up with RUHS's design. It's a very simple design. It's consists of basically two pieces. It's clear acrylic sheet plastic. It's approximately 20 inches tall by 22 inches wide by 20 inches deep. So the original design had two handholds in the back. They're approximately 4 inches apart, just above center, and they're 5.5 inches in diameter each. The team then requested that we put one on each side, left and right side of the box, for bagging. And those were also put just above center line, and they're also 5.5 inches in diameter. The thing that we did differently, and mainly for cleaning purposes, is we actually heated up the plastic and put the sides down. And then that also made it more durable. They were very impressed, and other than the two holes on the side, everything else was working perfectly for them.
When we tried this, and we have not used it on a live person that is needed to be urgently intubated, from having a live person lay in there and mimic a true intubation, we found it all very useful and easy to use. It wasn't something that I thought that in an emergent situation I would be able to adapt to. It seems a very natural adjustment to make in that acute situation. So one of the reasons we thought it was necessary to spend time and energy on building this box is we know that we have increased aerosolization with positive pressure bagging and intubation. It's one of the highest risk procedures that we do on COVID positive patients throughout the hospital, because we know that it is an airborne virus that can carry far, especially with positive pressure ventilation. So this is giving us one more line of protection for those of us to intubate, to hopefully prevent any of our healthcare workers from getting sick. It also maintains all of the aerosolization in the box to prevent the respiratory therapists and then later the nurses that walk into the room from having any aerosolized coronavirus.
Wow, that was an excellent video, everyone. I hope everybody received it okay. Dr. Mittal, any other comments beyond what we were able to learn from the video?
Since the time of the video, we have actually used it in an intubation, and we felt that it was kind of exactly as we had dry run it. So very functional, very easy to adapt to, and we did feel kind of there was that extra level of protection that we were looking for.
Wow, great. And did you have any challenges with that patient that you worked with?
We are thinking about maybe asking for a few slightly higher. I think he said it was 20 inches in height. I think we may ask for about 24 inches in height, just because the patient's head was a little bit bigger. So with the ambu bag and the patient's head and all of the manipulation of the tools, it seemed a little bit tighter.
And are you using video laryngoscopy when you're using the box to help with visualization?
Yeah, so we're using the video laryngoscopy. We also thought this has two benefits. One, our face is further away.
Yep.
Two, with the tool, the blade inside the box and the video screen outside the box, if there is any blood or sputum or anything that gets on the box, that doesn't really inhibit our visualization of the airway and our attempt to get a successful intubation.
I see. I see. I do want to open any questions up to any of the participants on the webinar here. If you do have a question, please don't hesitate to enter that in the chat box, or if you'd like, go ahead and unmute your phone or computer and let her rip. Okay. So Dr. Batala, thank you for what you've presented here. Again, this is another great innovation that our team here at RUHS has been able to put together, and certainly, like, there's no question, will improve staff and provider safety, and ultimately that is our goal here. While we have just a little bit of time, maybe we can ask you about some of the surge planning that has been ongoing over the last couple of weeks within the intensive care unit, with the anticipated surge that the modeling suggests. We are in the stages of really looking at how to expand ICU care within a hospital that has a confined number of ICU beds. So I know you've been working hard on that. Maybe you can explain kind of what you've been working on and what your anticipation is there.
Sure, yeah. So currently our normal capacity for an ICU is 36 beds. We have one unit that has 12 beds that's allocated for surgical ICU, and then a second unit that has 24 beds allocated for medical ICU. We are in our surge plan 2, essentially, of our staging, where we have separated and taken the 12-bed ICU for our COVID patients. Currently, there are 6 COVID positive or PUIs in our hospital. And then our surgical and medical ICU are together in our 24-bed ICU. We, in the scope of new places where we could put ICU patients, we spent a lot of time walking around places we wouldn't normally have ICU patients, and decided that our pre-op holding and potentially our PACU, as well as our same-day surgery, would be other sites where we could hold ICU patients and flex over, given the monitoring, and the ability to have vents and multiple patients in one area. We further flexed out, or have the ability to flex out, if we have 50 ICU patients combined, to take over one of our wards, the 2500 ward, which used to be our intermediate care PCU. And then after that, it kind of flexes out and out and out to encompass, we built a plan to encompass 200 ICU beds with physician oversight. And that essentially is almost every ward in the hospital. So it has definitely been a challenge to plan these things, because planning for something that we have never, ever undergone, and how many patients can we adequately, each intensivist, care for, and what kind of structure under that intensivist, and what kind of respiratory therapy support and nursing support, right, and CNA support do we need for each of those different flex plans, has been definitely a big challenge and quite a learning process. We have the benefit of working very closely with our surgical intensivists, anesthesiologists, and ER physicians. So they are involved in our inpatient flex care plan, providing extra day and night coverage for extra ICU teams from our surgical ICU, and then cross coverage at night from our ED and anesthesia colleagues. So I'm grateful that this has very much been a team effort. Looks like nothing unifies everyone in a hospital as strongly as a pandemic does, but it's nice to see that everyone in the building has really stepped up and offered their supportive services. We've even gotten emails from the pediatrics department asking how can they help, what can they do. They're happy to do anything, and it's been really a light in kind of all of the chaos that is, that everyone is so willing to help and be on the team.
Right. Well, very good explanation there. I think there's no question that the team effort has been outstanding, not only within RUHS, but the collaboration at the EOC with the 17 hospitals in the county has been something great to see, and I think we're making great progress with the collaborative effort around the county, and this webinar is really a small piece of that, really to bring the clinical staff from all the 17 hospitals together and really sharing ideas and innovations that we've been able to put together here at RUHS. So I think it's been a great opportunity to join together, something that we don't wish will ever come back again, of course, but the collaboration has been outstanding. Are there any other questions out there, either via the chat, or you can go ahead and unmute your phone? Okay. So I do want to remind folks that you have the address to the YouTube channel. We have all the prior videos and the video here of Dr. Mittal and team. So please take a look at that, share them with your colleagues if you find them useful. And again, just kind of expanding our collaboration around the county is our goal here. So we are just about 25 minutes in, which is within our target. I want to again thank Dr. Mittal and the rest of the team for putting this webinar together, and we'll go ahead and close this webinar and allow everybody to get back to work. And as I've said before, please everybody stay safe, and all the best to you. Take care.
Thank you.